Good afternoon, good evening, everyone. This is Dr. David Clark, and I'm speaking to you from the great Pacific Northwest in the West Coast of the United States. I want to welcome all of our attendees. We've got quite a prestigious list of doctors joining us tonight. I want to thank you for joining me. I want to make sure and welcome everybody in as many languages as I can, so I want to say buenas noches, buonasera, konnichiwa, and I forgot my Italian, or I forgot my French. So anyway, I want to welcome everybody. I understand that a few of you have English as a second language, so I will try and be as clear as possible and speak a little more slowly than normal. You can go ahead and ask questions as we go along. And I want to let you know I'm very excited about this webinar about really this incredibly important topic of treating deep caries. And there's been a lot of advancement in implants and aesthetic dentistry and CAD/CAM. And one of the really the tragedies of modern dentistry is, and when I talked to Rella Christensen down at CRA, is that we really haven't gotten a good recommendation for doctors about what to do with deep caries. How deep should I cut? When should I cut? When should I not cut? When should I expose the pulp? These kinds of questions. So we're going to talk about this very important everyday type of dentistry that I think is a little bit lacking, and so I'm excited that you are here with me tonight. All right, so we're going to get right into it. I'm not going to go through my normal introduction. A lot of you have seen my lectures before. There are probably, I think, 4 webinars on the 3M website. I want to thank them for hosting me today. But like I said, I want to get started right off into the discussion. So take a look at the screen. And a little bit of background about this patient. I'm going to move my cursor around here. A little background about this patient. This patient is new to my practice, and these teeth are completely asymptomatic. He has no pain to cold, chewing, heat, which is often the case with these deep caries cases where they're asymptomatic. So I will be having this little cursor. I'll be able to move this around to wave at the slides. And so let me go ahead and go to the next slide. And here we are post-operatively, and this is the way that I treated this in a very different way than I would have treated in the past. So we'll talk about this case sort of on and off throughout the lecture today. How did we achieve this post-operative result without exposing the pulp, with incredible patient comfort, and with a material that is going to resist leakage and recurrent caries? And I'm very happy to be living in a time when we have better materials to do composite dentistry than we've had in the past. So we're going to talk about modern composite materials for deep posterior applications. So let's go ahead, and what I'm going to do first is I'm going to go to the next slide. And this is the preoperative and postoperative. So I want to say a couple of things first. Is that number one, we were able to achieve very large, very broad contacts. That's part of creating a very comfortable tooth. The second thing that I did in this particular case, you'll notice here on this second bicuspid, I went ahead and immediately placed a composite onlay or composite overlay. And that's one of the things that I'm going to recommend, is that when you have a deep caries case like this, instead of creating mechanical retention with a traditional GV black preparation where we cut a box in the tooth, if you cut a deep box in a tooth like this, you're going to expose the pulp and weaken the tooth dramatically. And you can look at some of my other webinars. We talk about putting composite in a tooth like this does not prevent tooth fracturing. So we went immediately to a composite onlay. Here's one of the other things that you're going to notice on this radiograph. You notice a little bit of darkness here in the center of the tooth. we're going to leave a little bit of carious dentin over the pulp horn. This is modern caries removal. I'm going to talk to you exactly how we do this. And when we leave infected dentin deep in the tooth near the pulp, as long as we create a very beautiful external seal to the tooth and very careful about removal of caries around the periphery or the outside, I'm going to talk to you about the research that shows that this is the way we want to do modern caries removal. So any conversation about liners or bases or adhesives, the first conversation, before anyone talks about an adhesive or a liner, the first conversation should be about how we cut and how deeply we cut and when do we leave a little bit of caries or a moderate amount of caries deep in the tooth over the pulp horn. So, all right, here we go. Now what I'm going to do next, let's go to the next slide. What I'm going to do next is I'm going to run this little tape. This is a patient, this is the patient who had these deep caries. He came in a month or two afterwards in for a cleaning, and so I interviewed him to talk to him about these 3 teeth, because in the old days, I think I would have had a very different response. I would have either had to start root canals, or the patient would have had a lot of sensitivity, or the patient would have had food impaction. And so I want to just interview the patient quickly about his experience. I'll go ahead and hit the play button here. Hope you'll be able to hear this. So this video will show the before and after once again.
Tell us in 30 seconds or less your story.
After, it's probably maybe a 3-hour appointment, maybe longer. I had 2 days of maybe a little sensitivity, and after that, my teeth feel great. Floss well, no sensitivity. Feels like I never had any work done.
Those are some big.
So here's the preoperative. It's fine. I've just changed the digital X-ray, so I'm going back from old-fashioned X-rays to the post-operative here with digital X-rays. So anyway, this is fun. Having patients have 0 post-operative sensitivity is the new goal of my practice. I have a lot of patients who are referring other patients because of 0 post-operative sensitivity. I'm not doing as many crowns as I used to. I do onlays. So this commitment to 0 post-operative sensitivity and 0 pulpal death, I've been doing dentistry for 25 years, and it's exciting. It's exciting to have this kind of comfort. So let's talk for just a minute. Let's talk for just a minute about your practice, about growing your practice. And I'm going to go ahead and put up a slide here. It's kind of interesting. I spend a lot of time lecturing and talking to doctors, and post-operative sensitivity is a huge problem with patients, and a lot of doctors are still having lots of problems with post-operative sensitivity. So let's go online. Let's go online and take a look at, in the United States, we have a lot of people going online and rating their dentist. And in fact, this can either be a big practice builder or a practice killer, because more and more patients are evaluating we dentists with these reviews. So here's a review. I'll just go ahead and read through it. After my 6-month cleaning, my dentist made 1 filling on tooth number 30 and another filling on tooth number 29. For those of you not in the U.S., that's a bicuspid and a molar, lower molar. After several days, these teeth continued to ache. Now, obviously, these teeth were not in pain before the patient went in, otherwise they wouldn't be surprised. So these are teeth asymptomatic. He went into the doctor, and now these teeth are aching. I returned to the dentist, and he drilled the filling down for a better fit. So he adjusted the occlusion. After a week, that didn't help. So then he went back to the dentist, and he gave him a prescription for antibiotics, which makes no sense. Then after taking the prescription for a week, the teeth were no better. He called the doctor again, and this time the doctor says, okay, your teeth are in pain. Let's do crowns on the teeth, which is also not a very good idea. So now the patient doesn't want to go back to this doctor. He's lost trust in this doctor, and now he doesn't know what to do. And this is such a huge problem. And you can go to so many websites where patients are complaining that they go in for a filling and the postoperative sensitivity is lasting for weeks or months or years. This used to happen to me also. So the first thing we want to talk about is eliminating postoperative sensitivity. So we'll talk about the process that we used in this case and the specifics on how we remove the caries. We'll go through every step of this today. All right, so this is actually a picture from the internet. This is something I want you to remember. Here's a picture of the cemento enamel junction on a tooth. Here's enamel. Remember that enamel is a mineral. You can cut enamel, the patients don't even feel it. The minute we cut the dentin, these dentin tubules lead right into the pulp chamber, and most of these dentin tubules have a nerve inside of every dentin tubule. And look at these dentin tubules. I want you to think about this, how different the dentin is. The dentin and enamel are unrelated. So anytime we cut into dentin, we have to think about the fact that dentin is live. Dentin is completely connected to the pulp. So we need to think about that every time we cut dentin. So every time I have dentin, I'm worried about these dentin tubules. So I'm going to go ahead and give you a tip right away. And I have converted over to Scotch Bond Universal because I like the way that it wets dentin. It has a great affinity for dentin. So I'm using Scotch Bond Universal. This is tip number one. If you'll massage or agitate the Scotch Bond Universal into the dentin for a full 20 seconds, and then air thin it gently to drive off the solvents, and then light cure, you're going to have a dramatic reduction in postoperative sensitivity. A lot of doctors are not spending enough time to massage that into the dentin, and a lot of dentists are using older dentin bonding agents, and that's okay, but if you're using an older dentin bonding agent, the research actually tells us that you will need to apply 6 or 7 coats of adhesive to some of the older dentin bonding agents, either air thinning and curing or applying and air drying and applying and air drying. So I want to repeat that. With some of the older dentin bonding agents, they had such a bad affinity or a bad wetting of dentin that you had to put them on the tooth 7 times to get a good plugging of those dentin tubules. So you want to go ahead and agitate the Scotch Bond Universal for a full 20 seconds into the dentin tubules. If you get acid etch on the dentin, that's okay. Doesn't matter. Just make sure and give this time to penetrate the dentin tubules. Now, how long does it take the Scotch Bond Universal to penetrate etched enamel? About 1 second. So remember that when you're putting resin on enamel, just wet it, air thin it, you're done. On dentin, a full 20 seconds. Just think about those dentin tubules. All right. Now we've got several questions, and we're going to go ahead and answer some of those as we go along. I already see a lot of people asking questions about leaving caries over the pulp. We're calling this directed caries removal. Most of the major dental schools internationally are now teaching this, and so I don't want anyone to panic about leaving caries behind. We'll explain this as we go along. So what we're going to be talking about today also is the state of the art of flowable composites. Now we're basically breaking flowable composites up into 2 different types. We've had the traditional flowable composite, and I want you to go to some of the webinars that I've done for 3M, and we talked about traditional flowable composite. I like to call it pretty flowable composite or beautiful flowable composite. We have a new flowable composite by 3M, and there's a few others out there, but I really like the 3M, which is what I call low stress or bulk fill 3M flowable composite. We're going to be focusing on the bulk fill composite. We only really want to use this in the posterior teeth because the aesthetics are not as nice as the pretty flowable, but there are so many advantages to the bulk fill that we're going to use this in almost every posterior tooth because of its unique abilities to seal the restoration. And so I'm going to go ahead and go over some indications for traditional composites for just a minute, and you can see these when I talk about pretty flowable composite. It's the white and blue syringe. These are on previous 3M webinars. You can take a look at this, and this is what we did with flowable in the past. We're able to take flowable, inject it into the biochrome matrix, and get these beautiful anterior composites. This is part flowable and part paste composite. So beautiful. So I've simplified my process when I use Filtek Supreme Ultra. This is all the pretty composites that we use in the anterior. white and blue. I don't use a lot of these other things. We've made it very simple. I just use body shade in most of these cases, and I use the flowable composites are all body shade. They match beautifully. I want you to take a look at a case that I did. This is the Biochrome matrix system. We do a lot of work together with 3M. I've developed the Biochrome matrix system. It's all these beautiful anatomic matrices for aesthetic dentistry, diastema closure, and anterior restorations. Here's the diastema closure matrix from BioClear. Here's a case we're using traditional flowable for a peg lateral. About 7% of the population has an undersized or peg lateral. There it is. We removed the biofilm. We're going to put the traditional flowable down. We put about 2 millimeters. We light cure that. And then we go ahead and wedge that. This is called delayed wedging. For any of those who've taken these hands-on courses, you've done this. We inject the flowable and paste over that, and it's a beautiful result. They're strong and wonderful. So that's anteriors. That's traditional flowable composite. We're not talking about traditional flowable composite today. We're talking about the new bulk fill flowable composite for posteriors. So now we're moving to back teeth, to posterior teeth. I want you to take a look at the slide. A lot of us are still using amalgam. It's a great material. It's just, obviously it's being phased out all over the world. But one of the advantages to amalgam is amalgam was condensable. You can condense amalgam. Now the problem with composite is it's not condensable. When you try and compact composite, bad things happen. The more you pack it, the more you manipulate it, the worse it gets. So that's why we've developed flowable composites, and that's why we're talking about injection molding of composites, because composites are not condensable. So here's a slide of that was in a hands-on course where a doctor was trying to put 2 layers of composite in. Here's the flowable composite in a class 2, and here's the paste on top. There's 2 problems here. Number one, this is traditional flowable composite. It shrinks and opens at the margins. And so we're going to talk about low stress or bulk fill flowable. It has a tendency to not pull away from the margins because it relieves the stress of shrinkage. Now, it's not as beautiful as this. It's more translucent. We'll show you that. And then once we've put the flowable composite layer down, we'll show you how to marry the paste composite, which we put on top, to the bulk fill flowable on the bottom, so we get away from these sorts of problems, which are epidemic with posterior composites. This is such a huge problem. So this is what we want to be doing. We're going to go in and we're going to put an initial layer of low stress or bulk fill flowable composite over the dentin. We're going to seal the gingival margin. We'll put down about 1 or 2 millimeters here, up to 3 millimeters deep at a time, because it does have high depth of cure. We'll cure that, and then we'll put paste over the top, and I'll show you how I marry the 2 layers together with the low stress flowable and the paste. So in a traditional boxy preparation, which hopefully we don't do a lot of these old-fashioned preparations anymore, that's how you would take care of that. With the saucer preparation that we teach in the hands-on courses, and you can read about the saucer preparation, the less invasive preparation, we're still going to use bulk fill flowable to replace the dentin and then to cover the gingival margin. We'll light cure this, and then we'll inject flowable and paste together to create a nice helmet or an outer coating of paste composite. We do not want to use just bulk fill flowable for the whole cavity. It's not strong enough. So we've done this 100 different ways. Today, this is the way that we want to do modern composite dentistry in the posterior. All right. So there are a lot of these articles available online that I've written. If you go to the BioClear website or search these online, talk about a lot of these different techniques. This is the bulk fill flowable composite. So once again, we have 2 kinds of composite. We have the pretty flowable that I showed for front teeth and some of the techniques that we do with the Biochrome matrix. In the posterior, this flowable composite allows us to do some beautiful things. And when this composite shrinks, it absorbs the stress. And under the microscope, I was so impressed that the margins, under the microscope, there were no white lines, there was no stain. This is a beautiful material deep in posterior teeth for buildups and to provide that first layer and to use basically as a base. All right, so let's take a look at some of these charts. This is boat fill flow. This is the boat fill with flowable. It has a fair amount of shrinkage. It's 3%. That's not the benefit. That's a lot of shrinkage. What happens with these composites is when they shrink, they absorb the stress and they don't pull away from the margins. So it's not low shrinkage, it's low stress, and it works. I am so impressed with this. I'm so glad to have this in my practice today. You take a look at some of the other shrinkage. It's fairly consistent. That's a lot of shrinkage. Anything that's above 1% is going to create a problem unless they mitigate the shrinkage by having low stress. So this has low stress, but they all have fairly high shrinkage. So here we are looking at some of the shrinkage of all these boat fill flowables or boat fill restoratives. And this is the key right here, shrinkage stress. In other words, this is cuspal deflection, or how much does it pull the cusps together. And this is fairly low. This is a fairly low cuspal shrinkage, or cuspal deflection. So this is what we want to see. Now you see a couple other bulk fills up here, and these are okay. I used to use SureFill SDR, and it was the first good low stress flowable. I don't use this anymore because it's so weak. And if you put any of this on the margins, which always happens, it has terrible wear resistance. It's more sort of, it's like almost like a temporary flowable, but it has good stress mitigation, but I don't use this anymore because it's not strong enough and because it does not have good wear resistance. So we moved on from that. So shrinkage stress, this is great. Look how low the shrinkage stress is compared to some of these other traditional flowable composites. So there's not even a question, folks. If you're in the back of the mouth and you've got a cavity on Dentin, I'm going to put this flowable, the boat fill flowable 3M down first before I injection mold anything over top of it. I'm going to put it in deep in the cavity, cover the margins. It's fabulous stuff. It's just not very aesthetic, and that's okay. It's deep in the posterior. It's usually not visible. So that's where we are today. We need two flowables, doctors. We need a low stress flowable, and the aesthetics are not so great on that. So that's in the back of the mouth, and in the anterior, we're going to be using the pretty flowable composite, the traditional flowables, like we have, like we talked about previously. Okay, so this we want to use in the back of the mouth. All right, so let's talk about this. Let's talk about this modern caries removal. And I am a microscope dentist, as many of you know. I try to do the world's most precise dentistry, and I would like for all of my restorations to last for 40 years. 40 years is what I like. So to leave caries underneath the restoration to me seemed very wrong. But when we read the research, and now that I've been doing this for about 8 years, the outcomes are incredible. If you're going to ignore science, then that's okay. But the science is telling us that doing directed caries removal and keeping the pulp vital is part of modern dentistry. And there are multiple studies. So let's take a look at a study that was done. Long-term survival of indirect pulp treatment performed in primary and permanent teeth. So here's a lower primary molar in the study. This was in the Journal of Endodontics. It's a great article. You cannot access this article unless you pay, unless you're a member of the American Association of Endodontists or pay for the journal. But there are other good studies out there. Now this is what they did in these children. This is the lingual of a molar. You can see this gross decay in here. Now they took out just a little bit of caries at the margin and then filled this with glass ionomer. And this is what they did to all these children, primary and permanent teeth, and just sealed the margins and left these alone. Now I take out a lot more decay than that when I do these cases, but I want to show you the results from this study. This is called the Hall technique, and they leave a clean margin and leave caries over the pulp. Over time, the dentin dries out, carious flora decreases, 10-year outcomes were excellent. Look at the outcomes from this study. The 3-year survival rate was 96% for primary teeth and 93% for permanent teeth. And these are all teeth that if you would have removed the caries completely, you would have entered the pulp chamber. There was no way that you could have treated these teeth in the study without doing endodontics unless you left a little caries over the pulp. So let's take a look at the success of endodontics, which is what they did in the study. Endo success is about 93% for vital cases, but if you look at, if you start to rule out some of these endodontically treated teeth that have a little bit of tenderness, I mean, they're successful, they haven't been extracted, but they're not completely asymptomatic. The actual success rate for endodontics, according to the study, is only 70%. So you have to ask yourself, do I want to teach myself how to do directed caries removal, selective caries removal, and get a 93% success rate, which I'm seeing in my practice, or do I want to do endodontics and at best get a 70% success rate when you consider that many of the successful endodontic cases still have little bits of pain? So, like I said, this is a decision that every clinician will have to make, but this modern approach to caries removal is not going to go away. All right, so I've got a lot of great questions that we'll answer here at the end of the lecture, so please hang on. We're going to go ahead and answer all these questions at the end, but I don't want to interrupt the lecture because we have a lot of material to cover. All right, so what should we use when we have proximity to the pulp? What is the best pulp cap agent available today? Now, there are a whole bunch of new pulp capping and bases that have all of a sudden gotten popular. We haven't seen a lot of these for a while. Now all of a sudden they're selling a lot of these. So should you use a liner? Do you need to use a liner today? Especially if you're going to be leaving a little bit of caries deep in the restoration. So the question is, what is the ultimate pulp capping agent? Should we use Dical that stimulates secondary and tertiary dentin formation? Should we use resin-modified glass ionomer? And the answer is, I'll answer one of these right now. If you're using Vitrabond or Fuji or one of these glass ionomer linings and you like it, and Vitrabond is the number 1, you can continue to use it. It's very good material. There's nothing wrong with it. However, if you don't want to use Vitrabond, then we're going to give you another choice today. Should use MTA. Expose the pulp and put MTA over the pulp, which is expensive. This is Dentin in a capsule, Septodont. This material is very hard to use, and if you have an accident and an inadvertent exposure of the pulp, that's different. This would be okay, but this is the Sterical that's new. Should be using this stuff. Should you use bonded resin as a pulp capping agent? None of the above. Well, according to the research, the world's best pulp capping agent is a well-sealed margin and a beret of Caries dentin. Now, for those of you that don't know what a beret is like a little hat that the French folks wear. That little tiny hat is a beret. In other words, the best pulp capping agent in the world is Caries dentin because over time it allows the pulp to heal itself. Now, what about a necrotic tooth? What about an endodontically treated tooth? No, all the caries has to go away because there's no pulp to heal the dentin. So let's go ahead and move forward. What are the new goals of pulp capping therapy? So when we looked at that case, that first tooth, and he had deep caries, what's your number 1 goal when you have a patient who's asymptomatic and has deep caries that you could potentially run into the pulp? So the first goal of modern pulp capping today is don't expose the pulp. Whatever you do, don't expose the pulp. Okay, number 2, don't expose the pulp. All right? All the things that you want to try and do in a deep caries case, that's the second most important thing. And you're probably going to guess what the third most important thing is. Don't expose the pulp. There is no need to expose the pulp on these deep caries cases. I'm finding ways. I'm teaching myself. I've got hundreds of cases I'd love to show you of crazy ways that we were able to go in, get a beautiful margin, keep the pulp alive, and have a 93% chance for success. And these restorations should last for 20 to 40 years because the margins won't leak. They're not going to leak. I know this is new for some of you. You're going to have to look at the research, but like I said, this is the modern direction. Okay, so why bother? Why don't we just go in and do endodontics? Well, one thing is we can get a better success rate than endodontics. And there's a couple other reasons why we'd like to keep these teeth alive. One of them is proprioception. It's nice to have a tooth with a pulp. And some folks talk about it like it's like not having brakes in a car. You really would like to have the pulp in a tooth. And there are other reasons, such as, of course, the endodontic access weakens the tooth a little bit. But here's the number one reason for me today that I want to, especially for an anterior teeth. Vital teeth, teeth with a pulp, have better color stability than endodontically treated teeth. Endodontically treated teeth almost always discolor, no matter what you do. No matter how well sealed these teeth are, they tend to discolor, and their roots turn dark. And you can see that through the gingiva and through the bone. So keeping the pulp alive in a modern era where the color of teeth is important, vital teeth, I'll tell you what, every year I get more and more committed to keeping the pulp vital. All right. I don't do direct pulp capping. If I have an exposure of the pulp, I'll usually do the endodontic treatment. Like I said, in the case of an accident on a vital case, you can use the Septodont material, but really that's not what we want to be doing as our plan, because the goals of treatment have changed. The literature is going to talk about almost any way to do pulp capping. It's pretty much chaos out there. I want to talk about this very quickly, and then we're going to go to some techniques and I think some things that will really interest you. If you're going to do pulp capping in a case like this, you need to go through the list. So when a patient walks in and the radiograph shows deep caries, you need to ask the golden questions. And here are the questions. Have you ever had pain that wakes you at night? Does the pain ever linger for more than 2 or 3 seconds? If they have pain with caries, you need to do the endodontics. If they're having pain, you need to take the pulp out. But if they're asymptomatic, let's keep the pulp alive. So let's take a look at the radiograph, look at the pulpal anatomy, learn where the pulp horns are so you can avoid them. You want to talk to your patient about risks, of course, and of course we have to be able to seal the restoration. If you cannot seal the restoration, then you probably should do endodontic therapy, because leaving a leaking restoration in a case like this is not the idea. I want to get a 40-year seal, and I know you can do this. All right. So, and then we're going to talk about the biochromatrix system as we restore some of these teeth in conjunction with using the 3M materials. This is the biochromatrix. For some of you that haven't seen this, this is the matrix that we use on anterior teeth for diastema closure. The biochromatrix system, this is for my friends in Germany. Was ist das Biochromatrix system? What is the biochromatrix? It's very thin. It's only 50 microns. They're very strong. And so we're going to be using the biochromatrix when we do some of these treatments. And I'll show you this in just a moment. We have 3 different shapes for the biochromatrix because there are different shapes to teeth. So in a very tight embrasure, we're going to use a flat matrix. We have an average curved matrix, and then we have a diastema closure matrix to close a large space. So the change in emergence profile, or in Spanish it's called a cadera, in German that's called a Hüfte, or a hip. In French it's an ange. So the hip that we create is important to get a solid contact. That's the other part of having a comfortable tooth, is picking a matrix that has the appropriate curvature. So this is the biochromatrix with the multiple curvatures that are available. So one of the other ways that we have an ideal comfort after a restoration is to create a big, wide, strong contact, not these stupid little point contacts. So having great postoperative having a great postoperative result as far as comfort for patients is dependent on multiple factors. Nothing is more important than a contact. And contacts are like money. You can't have, or no, they're like friends. You can't have too much money. You can't have too many friends. And your contacts in a posterior really can't be too wide or too strong. So I'm going to give you 5 keys to getting great postoperative results with your contacts. So these are the things that we want to do to get a great postoperative comfort. It's not just closing the dentin tubules. It's not just avoiding the pulp. It's also creating a solid, strong contact. So these are 5 things that I do to get a great contact in a class 2. The first thing you want to do is pre-wedging. When we do pre-wedging, we want to go ahead and place a soft wooden wedge, or you can try other wedges that are available, to compress the soft tissue, protect the rubber dam, protect the gingiva, and push the teeth apart. This is so important. Pre-wedging. In other words, wedge the restoration before you cut it. Now, in a moment, I'm going to show you a case from start to finish, a video where I go through all 5 of these steps and do selective caries removal. Take a look at the interproximal, study the radiograph, and decide, is it a tight embrasure, flat, is it an average, or a diastema closure embrasure, and get the matrix that has the appropriate curvature. What I do on every case is I'm going to take a 3M disc and I'll flatten the neighboring tooth. A lot of those neighboring teeth have rough contacts from old restorations, and even if it's a virgin tooth, I'm still going to flatten the contacts slightly so that I have a beautiful, broad contact. We don't want a point contact in composite. It just doesn't work. I want a low-profile wedge. We'll show you what that looks like. I don't want a tall wedge because that's going to interfere with the contact. And then I'm going to walk the matrix over. You'll see how that works in a minute. When we walk a sectional matrix over, it's not burnishing, it's a little bit different, and we'll use that with a separator. So those are the 5 keys to a great Class 2 contact, and frankly, you need all of them. You need to do all 5 of these things on a consistent basis to get a great contact. All right, so let's just take a look here. This is kind of funny. This is about 40% of dentists in the world are still using a Tafelmeyer. Now, Tafelmeyer gives a pretty good margin, but it gives a terrible contact. Now, here's why. Is this. Now, this is funny. Now, this is a joke, and I know that a lot of you are not in the United States, and you may not understand the humor, but I'm going to try and have a little joke here, all right? So, when I take a look at that Tafelmeyer matrix, it reminds me of these little collars that the dogs wear. In the United States, it's called the cone of shame, or the Elizabethan collar. And this is what animals wear so they can't lick themselves when they have a problem. So when I look at that Tafelmeyer, I think, this is what this silly dog wears around my house. And the problem with this cone of shame, or this Tafelmeyer matrix with composite, is it gives these point contacts. And this is not a good contact. This is uncomfortable, and it's very prone to fracture. To be able to get a beautiful contact, we need to come out and have a rounded emergence profile and a wedge that doesn't create this stupid point contact. And the world is full of these bad contacts in composite. Remember, teeth are round. Look at all these beautiful rounded emergence profiles. So you need to have a matrix that has enough curvature to accommodate that, and a wedge that doesn't interfere with the curvature. Like, so these are the matrices. This is a case where I'm doing back-to-back using the biochrome matrix and a saber wedge. It's low profile. And there it is postoperatively. This is with Filtech Supreme Ultra Paste. And we use the low stress underneath. We'll show you how that works. But it can be so beautiful and such beautiful broad contacts when we do those 5 keys. All right. So I hope you're having a good time. We're going to get to your questions here as we move a little bit along in the lecture, but I'm going to keep all the questions to the end. So this is this is actually case number 1. This patient has deep caries, as you can see here. And it's been 23 years since he's been to the dentist. So here we are preoperatively. So I'm going to go ahead and show the movie here. And there we go. All right, so I'm going to back the movie up, or I'll pause it here for, I guess I can't back it up. All right, so you'll notice that I put the pre-wedge in before I cut the prep, and that's that large blue wooden wedge. You'll notice how deep the caries are in this case. Remember, what's the number 1 goal of pulp capping? Don't expose the pulp. What's number 2? Don't expose the pulp. What's number 3? Don't expose the pulp. Now, as I get deeper into the tooth, I like to use diamond burrs. Diamond burrs have great control. The other thing I'm going to do in this case, because there's so much dentin exposed in this aging patient, you cannot keep a permanent seal when your margin is on dentin and it's in occlusion. If you try and put a margin here on dentin, it will leak and stain. It will not be permanent. We do have to cover dentin margins on the facial, that's fine. But when we have exposed dentin on the occlusal, I'm going to cover that, and in this case, I'm going to go straight to a composite onlay or overlay so that we can provide a long-term result for this patient. So, all right. So, well, actually, good, I get to start this again. So here's the pre-wedge. Look at all the dentin that's exposed. I'm going to move to an immediate composite onlay because composite does not splint the tooth. If you put a traditional GV black box in there, then eventually the cusps can fracture because composite does not splint the tooth. So this is one of the things that we teach in the hands-on courses, the design for this composite onlay. You need about 1.5 millimeters of cuspal reduction and able to do the onlay. So this is, as we're proceeding with the preparation, there's my pre-wedge. You'll notice we've got dentinal caries that's still in the preparation. Now, caries indicator is helpful. Now, what I want you to notice is, here's all the caries next to the pulp horn. I'm not worried about that. I am very worried, I would say very, I'm stomping my foot, I'm very worried about the caries at the dentino-enamel junction, here and here. As we chase the caries into the tooth, you're going to find out that there is a good amount of tooth structure on the outside of the tooth that can be left undisturbed. This is not a GV black cavity preparation. This is a modern cavity preparation. So we're going to be careful about not removing the caries here, but we're going to be very aggressive about removing caries at the margin. How much clean tooth do I need? 2 millimeters. I need 2 millimeters of clean tooth at the margin for this to work. So let's go ahead and roll the tape. So I'm going to chase after the caries at the dentino-enamel junction. This is key. And if you're not using magnification, I want you to get some loops. If you're using loops, get bigger loops. If that's not good enough, you can get a microscope like me. So I'm checking to make sure all the caries is gone at the dentino-enamel junction. I'm going to show you what this looks like clinically. Like I said, the dental schools are all moving to this model of caries removal. So I'm just laying my diamond burr. I like a diamond burr. This burr is by SS White. You can email me about questions about which burrs I like to use. But this is a diamond burr. It has great control. And once again, I'm laying it against the side of the tooth and not cutting that last bit of caries. I'm not going to expose the pulp. The last thing I'm going to do is to put a little 45-degree bevel on the enamel. And we're about ready to restore the tooth. So I'm about to remove the wedge. Now, disinfecting of the dentin was not done in the study. And if you're going to do directed caries removal where you leave caries over the pulp horn, that dentin is probably impossible to disinfect. Remember, the pulp is going to feed that area. Over time, it's going to become sterile. It's essentially sterile. It's going to become hardened. And so disinfection of the dentin is really not part of my model because I'm allowing the tooth to disinfect that. If you want to disinfect it with whatever medium you can, I'm actually getting a little bit of disinfection with this. This is sodium hypochlorite or bleach. I'm using this just to get the color, that pink color, out of the dentin because I don't like to leave the pink on the dentin. And also I'll use a little bit of sodium hypochlorite or bleach just to remove some of the debris, some of the softest part of the dentin. You can massage that with a little applicator. You can massage it with a toothpick. I like to use a toothpick. If you take a round burr in here, you're going to expose the pulp, and that is not something that I do in my practice anymore. Oh, I did it again. I clicked the movie. All right, I'm going to let this thing run all the way through here. Now I can't hurry it along. All right, well, at least we get it. Yeah, we get a good chance to watch the video. All right. So once again, I'm removing caries, onlaying the cusp. I want to remove about 1.5 millimeters of tooth structure to be able to onlay the cusp. The margin is going to go about 2 millimeters past that second plane. You see about 2 millimeters of cuspal protection there. Once again, putting composite in a tooth does not prevent fracturing. If you want to stop teeth from fracturing, you need to do a different cavity preparation. So I routinely do composite onlays to prevent teeth from fracturing. The research is pretty compelling to tell us that intracoronal composites do not stop tooth fracturing, no more than amalgams do. So I'm checking to make sure there's no caries at the dentino-enamel junction. I'm going to put the caries indicator one more time. and you'll see a little tiny bit of caries at the cemento enamel, at the dentinal enamel junction. So I'm being very, very committed to removing all of the caries near the margin. This is why these restorations are holding up so beautifully in my practice. Remember, I'm using a microscope. This is not sloppy dentistry. This is modern, beautiful, microsurgical dentistry. I love this. I love keeping these pulps healthy. I love that my patients aren't having sensitivity. This is a wonderful way to practice. Now, we always take a lightning strip. Why do we take a lightning strip? To remove biofilm, calculus. Remember, your composite's going to flow past the margin a little bit. And without doing that, you're just going to have micro leakage. So I'm able to get more or less an infinity edge margin, even in a class 2. Now, because this was such a periodontally involved patient, I could use one of these. This is a BioClear soft wooden wedge. And because it was so deep, I went ahead and used a higher profile wedge. You can shorten those wedges and just cut the top off in a case where they're not periodontally involved. So here's one of the last steps. This is the BioClear separator, and a lot of you are using different separators. With the BioClear matrix, you're not going to burnish the metal. I mean, you can burnish metal, but with the BioClear matrix, you really can't burnish it. That's a point contact right there. You see that point contact? You do not want a point contact. So we're going to walk or pull the matrix over with the two tines of the cotton pliers, and because there's a separator holding the matrix against the tooth, it acts as a ratcheting device. So I want you to look at the contact now. It's a nice broad contact. And so you can only do that if there's a separator on the tooth. All right, so now we've got a big, beautiful contact. It's going to be wide buccolingually and incisogingivally. And now I'm going to etch the enamel. Now, I know a lot of you have stopped etching your enamel. I would not recommend that. There are multiple reasons that you want to continue to etch the enamel. And you want to etch the enamel for about 20 seconds. Now, if you can keep it off the dentin, that's okay. But I'm not worried about dentin sensitivity anymore with acid etching. Not when we follow the rules with Scotch-Bond Universal. And what are the rules? Massage the Scotch-Bond Universal for 20 seconds into the dent. I'm going to use acid etch for multiple reasons. And one of the reasons I use acid etch is because once the tooth is etched, I can examine the tooth. If there's a shiny area here, that may mean that there was biofilm or old composite or whatever it was. So I want to make sure and use acid etch to get a great bond to enamel, and also because I can inspect my enamel and see if I have a problem. So I'm going to use blue etch on my enamel till the day I stop doing dentistry. Oh my gosh, I hit the button again. Oh, I can't go back. All right. I have to show this. Oh, you're going to kill me. Okay, you know what? We'll watch the movie one more time. I am so sorry. I keep hitting the wrong button and I cannot cursor through my videos. All right. So while this is playing, I'm going to go ahead and answer a couple of questions because I can't seem to not hit the button here. All right. So let me go ahead and answer one question while we're watching the video for the third time. Let's take a look here. I have had so many cases with asymptomatic and no pain and no radiographic issues. When I open the tooth, the pulp chamber is empty. Where does that fall in what you have described? Ah, that's a great question. So there are a lot of cases where the pulp has died a kind of a quiet death and it is asymptomatic and it doesn't really seem to show up on radiograph. And so the only way that you would really know those cases, if you did a cone beam on some of these cases, cone beam shows us there are a lot of cases that radiographically we thought were okay, they're not okay. And what the other thing that cone beam teaches us is there's a lot of endodontic treatments that we thought were healed and the bone has not completely filled in. Doesn't mean that the endodontics are failing, but what it does mean is that that bone fill on some of these cases is not complete, and we also know that traditional radiographs are actually not very helpful compared to cone beam. So to answer the question is, David, why do I have so many cases that are asymptomatic, but when he opens in, asymptomatic and look good on the x-ray, but when I open in, there's no pulp in there? That's number one, that's part of the game, and number two is your radiograph, unless you have a cone beam, is actually crude. And I don't have a cone beam, but I understand that my radiographs are not telling me near as much as I need to know about the bone around the tooth. It doesn't change the fact that we want to move to a modern model of caries removal, and it's worth it. It's worth it. In a few of these cases that need endodontics, remember, you're going to be 93% successful according to the research. Now, one of the other things that we may see is that children may be better for this than older adults. Older adults may have a higher rate of where the pulp has quietly died than children. And the research that I showed was on children. So that may be one thing to think about. All right, so we're going to go ahead and do a total etch. I'm etching underneath the matrix here. We're going to go ahead and rinse this and dry. Now, one of the things, but if I hit that button again, somebody shoot me, all right? I want you to look at this. Even though this seemed like a very Dentin-driven operation, look at how much enamel is present with the composite overlay. That's going to stay in place. That's 70% enamel. That's a good number. So this is the yellow filter in the microscope. Now I'm going to massage the Scotch Bond Universal into the dentin for a full 20 seconds. Okay, massage, massage, massage. 20 seconds by the clock. Massaging into the dentin. All right? And we're going to air thin that. I'm going to light cure this. Anytime I'm bonding to dentin, I'm always going to cure that. And I'm going to go ahead and put a little bit of bulk fill flowable down. Now the wonderful thing about this new bulk fill flowable is that when it shrinks, which it does not shrink away from the tooth. It's stretchy. So when it shrinks, it does not open up those margins like traditional flowable. So if you'll use this, you're going to have a much, much better chance of not having sensitivity because it doesn't shrink away. Now I'm putting a second coat now. I've already covered up the deep part of the preparation. I'm injecting flowable composite, and then I'm going to chase that with paste composite on my second layer without curing them in between. This is injection molding. We do this in anteriors, and we do this in posteriors. Once you've covered the dentin and allowed that composite to the adhesive to set, and I've covered it with the Filtech bulk fill flowable, I can injection mold over the top with my typical injection molding process, which is get the complex wet with adhesive, then chase that with flowable composite, and then chase that with paste composite, just like an impression with light body and heavy body impression material. So this is the Softflex ET discs. I love these discs. Part of the art of composite overlays and onlays is you need to get good at using discs. They're very helpful for growth sculpting. This is a contact easy. This comes with the Biocare system that removes little bits of composite that are stuck between the teeth. And then we're going to go ahead and finish this with these beautiful 3M strips, the small ones, the narrow ones, not the wide ones. We're going to marginate with the brownie, and if you like, you can go to YouTube for my polishing video. It's called Dr. Clark's 3-Step Polish. So this is a shofu brownie. They're inexpensive. They do a beautiful job of margination. And then we'll go with coarse pumice and then the Jazz Polisher. So there's the coarse pumice. That's just coarse laboratory pumice. It's a beautiful intermediate step. And then this is the Jazz Polisher. Actually, this one might be the Shape and Shine which we use in Canada sometimes. They're very similar to get this beautiful, beautiful finish. These teeth are so smooth and so comfortable for patients. Now, you'll notice I'm not cutting deep anatomy in the tooth. Well, this patient has a lot of wear, so it wouldn't make sense to cut deep anatomy in this tooth. And if you cut deep anatomy in composites, they're more prone to fracture. So I'm not a big fan of cutting deep anatomy in these teeth because I'm always concerned about fracture of the composite. And you can look and see how broad the margin is and how nice things are marginated. And so it's a nice result for a difficult case. All right, now hang in there. We're going to answer as many questions as we can. I want you to look at the before and after radiographs of this case. So here we are before, here we are after. Now, one of the things that you'll notice with the bulk fill, with the Filtek bulk fill flowable, is that it's radiographically very dense. So can you see I want you to take a look at the after radiograph here. Here's the cavity preparation. Here's where we tunneled in to remove caries at the dentino-enamel junction here, left a little bit of caries dentin over the pulp horn, and 3 years from now, when you look at a radiograph, this should become very mineralized. But no one should mistake this for recurrent decay, because we see a lot of liners that are radio-opaque, radiolucent. I'm not worried that someone would think that I had recurrent caries here, because recurrent caries would be at the margin. So I want you to look here. We've got where we chased after dentinal caries here at the dentino-enamel junction, beveled the margin. Look how beautiful that restoration is. Broad contact, and look how radio-opaque the Filtek bulk fill flowable is. That's nice, because we don't want anyone mistaking that we've got recurrent caries. So these were the 5 steps to the ideal class 2, and these are the different discs I use: coarse, medium, fine, extra fine. Those are Softflex ET discs. I love those from 3M. So one of the other things that you can do to get a better preparation, and these things, it's beautiful, they all work together for you, is to change the preparation. So let's talk about how we change the preparation to do all of these things together. How do you get a beautiful contact? How do you have 0 postoperative pain? How do you have 0 chance of pulpal death, from direct exposure anyway? And there's always a risk of pulpal death, but how to get 0 pulpal exposures. So here's a case. We'll show you the slides. It's a very similar case. Asymptomatic deep caries. All right, here's case number 2. This is a real interesting case. This is a case that I've seen this patient for 20 years. Look at all these layers of dentistry. Here's a porcelain fused metal crown. Here's a Emax press crown. Now you'll notice that when you see Dr. Clark contacts, they're big and broad and beautiful. I want broad contacts. Here's an amalgam that I did 20 years ago. Look how beautiful that rounded contact area is, the rounded emergence profile. And I'm happy, I'm very proud of that amalgam that I did 20 years ago. Today I want to use composite. And so it's interesting that 20 years later the patient comes back and now she's got the same caries on the other bicuspid. What are the odds of that happening? So we did a beautiful job 20 years ago with amalgam. Today I'm going to do a beautiful job with composite, but it's going to be a lot different. All right? One of the things that I want you to really think about, and look at extracted teeth. Watch the way the dentin tubules go toward the pulp. In the cervical area especially, these dentin tubules are angled at about 20 degrees, and the caries follows the dentin tubules. So think about this. If you have caries here at the dentino-enamel junction, it's going to go deep in the tooth. So if I've got caries in here, why would I blow out or cut away a GV black margin like this? You're going to cut away all that beautiful tooth. And that beautiful rounded profile allows you to have a better contact and have less discomfort, because you're not going to violate the biologic width. So you need to change the prep. Let's talk about what that looks like. Now here's an incipient caries. We all know, we've seen these, and these are a lot easier to treat. I want to talk about the caries on this side of the tooth. This is very typical for caries in young adults and aging adults in the era of fluoride. I want you to listen very carefully. Fluoride has changed the way that caries progress, and you can read that in some beautiful studies that have been done. With so much fluoride now in the water and fluoride in the toothpaste, we have small cavitation, and the external of the tooth can be very strong because of all the fluoride, but then we have all this caries that tunnels into the tooth. So if we were to treat this the old-fashioned way, so we've got cavitation here, dentinal caries here, right into the pulp basically. If we were to do a GV black preparation where we cut a box, expose the pulp, and then cut all that tooth structure away, boy, we've really cut a lot of tooth structure away, and we've inadvertently exposed the pulp. So that's a GV black preparation, and that's also going to be very difficult to restore, because look at how deep your margin is. And if you put a wedge in here, it's going to fall into the prep, and you're going to get a concave contour here and one of those stupid little point contacts. So if you change the preparation, use your microscope, use your loops, follow the caries. This is what your cavity should look like. You're going to bevel the enamel, chase the caries at the dentino-enamel junction, chase the caries that go into dentin tubules, but up here near the pulp, you're going to leave a millimeter or two of carious dentin. It'll vary. The number one rule is you have to remove the caries at the dentino-enamel junction. You have to remove any caries that's within 2 millimeters of the margin, but once you get deeper in the tooth, that's where you leave the caries. And every case is different. It's a beautiful art form that we're all having to teach ourselves about modern caries removal. But look at the difference in the cavity preparation between a GV Black cavity preparation and this new modern caries. Very organic and beautiful, and perfect for composite. Look at how shallow my margin can be. If I do this appropriately, my wedge, everything will go better, and the patient will be much more comfortable. So let's take a look at this. We're going to go ahead and pre-wedge, right? That's a soft wooden bioclear wedge. And the patient had fractured enamel. I'll overlay that too. You can look at this later. You can follow some of the steps on this. I'm going to take my diamond burr, going back and forth, getting deeper and deeper, removing caries at the dentino-enamel junction. There's a tiny bit of enamel, believe it or not, that's still here. I'm going to go in here, remove caries at the dentino-enamel junction. It's okay to leave some undermined enamel now. That's all right. I need that enamel to help me support my matrix and my wedge, so I'll leave a little bit of unsupported enamel if I have to. There's the onlay preparation. The bioclear soft wooden wedge acts as a stop. It protects the rubber dam and the soft tissue. I'm going to take that wooden wedge out. It's all cut up. You can just smooth it and use it again. And now it's a custom wedge. Look at that beautiful cavity preparation. Little bit of caries deep over the pulp. Beautiful clean margin with an incredibly deep caries. Isn't that amazing? There's still enamel right there, but that's how caries progresses now in the new fluoride era. We always take a lightning strip across the margin to clean the biofilm and remove loose enamel rods. Here's the bioclear matrix with the separator. Look at how shiny that dentin is. We know it's clean. I've scrubbed the dentin with a little bit of bleach just to get the color out of there. Look at my beautiful margin. That's going to be a 20-year restoration. We etch everything, Scotch Bond Universal. Once again, Filtech Supreme bulk fill here because we want it to not pull away from the margins. You'll notice how this is very translucent. And that's why we don't want to use this in the front of the mouth. You'll notice it looks a little bit darker than a flowable. It's not darker, it's translucent. It's a perfect trade-off. Like I said, in the back of the mouth, we want Filtech Supreme bulk fill. I'm going to put down about 2 millimeters worth here, and then we'll light cure that, and then I'll injection mold with the resin, the flowable, and the paste. You can see this online, how we do the technique. And there was I had a little trouble controlling the composite here. It's not a problem. Once I did the overmold, I just took a little bit of resin and flowable and paste, put it right there, and polished it. It's a beautiful solid contact, zero post-operative sensitivity, zero chance that the tooth is going to fracture later because we've onlayed the cusps with 2 millimeters of composite. So we also use this material as a bulk film, as a build-up material. All right, so we'll summarize and get to the questions. Here we go. If you're using a resin-modified glass ionomer like Vitribond, you can keep using it. It's well tested. It's got fluoride release. It's great. Now, if you don't use it and you want to move on to my model, then you're just going to go and understand that Scotch Bond Universal has to be agitated into the dentins, and the bulk fill will help you. So I don't use any glass ionomers in my practice, but like I said, if you like glass ionomers, then keep using them. They're great. All right. Traditional flowable can be combined with paste, but in the back of the mouth, in a deep cavity, I'm not going to use the pretty flowable. I want Filtech low stress. Look at the 2R, sorry. Bulk fill flowables is my favorite as this deep caries, as a sandwich. It's also a great build-up material. I use it as my build-up material now. This pretty flowable, it's still the choice for anterior teeth, utilizing the bioclear method, all right? But the Spiltech Low Stress is the safest to use with high C factor, which is common in almost every Bactiv. So you can integrate either of these with Filtech Supreme Ultra Paste. All right. I want to invite you, if you'd like, we do lots of hands-on courses. This is a level 2 course. I just put this up here. Here's a level 1 course with anteriors, black triangles, peg laterals, deep caries. I'm going to be in India, in Mumbai. I'm going to be in Germany. So you can go to the BioClear website as far as hands-on courses. These are really enjoyable to do. And I want to put this little slide up, which some of you have seen before. So my question for all of you is, this is in the Pacific Northwest where I live, where it rains all the time. So my question is always, what's wrong with this picture? And if you'll notice carefully, the picture is upside down. You're looking at the lake here by my home, and there's the right side up picture. So the message here is, dentistry has been upside down from where I think it needs to be. The GV Black cavity preparations, basically everything that we've done for about 100 years in dentistry was great, and it was great for amalgam, but it really doesn't have any place today. And I know these things seem upside down to you, like the dentistry is upside down, but it doesn't change the fact that we need to move on to a modern dentistry